Thank you. Good morning, Sethuraman from AgSoft. So today we are going to talk about a platform called MEDplat. This is being used in India and in some countries in Zambia and Cambodia. And this is a platform which has scaled, and we'll talk about this. What are the common challenges that are there in this space, the community comprehensive primary healthcare space? So if you look at it, geographies vary. There are systems which are different in terms of its maturity, the workforce roles, and then the priority. So they need a platform that adapts to their situation. We heard about it. People were talking about it just now. And then there is also the disparate. Right now, what is happening is there are very different systems for different programs in each of these countries, each of these geographies. And they often operate in multiple disconnected ways. Yeah, so they happen in multiple disconnected silos kind of a thing. So, which is essentially the workforce is having to re-enter the data in multiple systems a lot of times. It's sometimes paper-based, it's sometimes digital systems, but then they are having to enter it in multiple different systems. So this is actually taking the time away from what they are supposed to be doing, which is actually talking to the people, providing them the healthcare that they need. So that is not happening. And also what is happening is that, when these systems, there are new things which have to be added, then there is a problem there. People have to go back to the coding to actually make those changes. And it takes a lot of time. Even if you have to add something very simple, it takes a lot of time for them to come to the developer, get it done. And then again, moving it to all those various people out there, that's a big challenge. And we see this in multiple countries on regular basis, multiple implementations have this challenge. So this is one important thing that we are trying to see as a challenge which has to be addressed. And then we talked about interoperability. Just now we saw wonderful speakers here talking about how interoperability is different for different contexts. And the seamless interoperability, right now interoperability happens, but it's more for data and reporting is what we see. However, what is important is probably how can the data inform precision medicine? How can a longitudinal health record be available to the patient themselves and to the providers when they need it? So that seamless interoperability seems to be a major challenge in most of the health systems that are present today. Now, how do we address these challenges? What are we learning and what are we trying to do with MEDplat? One, we understand that different geographies have different needs. So we can't be building for each geography. So the platform has to be configurable. So we are trying to make it very configurable. For example, in Uttar Pradesh, there's a program called eKavach that is based on MEDplat. There was a Japanese encephalitis work that had to be done. It was configured in 3 weeks. In Zambia, we worked with PATH. There is a system called CHIP that is running there, which is scaling up very well. And there, the entire multi-program configuration happened in less than 4 months. So these are things which are possible when you have a system which is designed to be configurable, rather than trying to go touch the code each time and make the whole program work all the way right from the beginning. So configurability is something which we have seen, which we have learned, is something which is very, very useful. Second thing is, when we are talking about interoperability, how can it be standards based? We know that we have the ICD standard, the SNOMED standards, but some of these systems are looking at it probably at a superficial level. So the system has to be interoperable. It has to follow these standards. And more important, when we are talking about interoperability, FHIR is the way to go. And we are doing that in MEDplat with FHIR interoperability. We are now able to exchange data between systems with any system. You don't have to really understand the system. It's a point-to-point or it's a bus. You will still be able to exchange data because it's all FHIR. All systems which can read FHIR will be able to read the data. And this also evolves rapidly with the system in the country. The country decides what they want. They know best. They have their needs. They have their priorities. the system should adopt to the environment and not the other way around. So MEDplat configuration workflow, say for example, a government says, okay, there is a protocol change or there is a new evidence. Maybe we have to HPV vaccination or the postnatal care protocol has to change. All somebody has to do is use a browser kind of an interface and go there and do whatever changes that have to be done, and it can immediately be sent to all the health workers on the field instead of having to have a separate drop sent out and all those other things which many of us in many implementations would have faced. And of course, this is open source. And the open source, it's not just about code somebody was talking about, and even the DG was talking about it. It's not about the technology, it's about the environment, right? And here the community is involved, the community in terms of both the user community as well as the community which is developing it. So while you put it out and make it open source, then people go look at it, they want to contribute, they can also download, use it for their purposes, and keep suggesting more things to be improved. So that's the advantage of open source and making it a DPG. And why this matters most? One, the question we have to ask is how can health systems implement changes effectively, faster? This is one question we have to ask for any system. And the answer is the way it can be configured. How can programs be configured? And that's important. The second question we have to ask is, are we ensuring that the frontline workers have more time for patient care? Which means the interface has to be simple, and that's easy said than done. And we have seen this in multiple cases. And it has to be very configurable again, so that if they have a problem, they want to change the language, they should be able to do it right away. And then with today's technology, whatever investment, are we investing in the technology or are we investing in the ecosystem? That's a question. It's not about what program, whether it is MEDplat or something else. It's about the actual, the investments. Are they staying relevant for a long period of time? I have RMNCH today. Can I add NC2 to it very quickly? And the data that we are collecting, is it being used for local action? That's the important thing. The data that is being used today is more for the dashboards, which is important, which is useful, which is for policy. But does it just do that, or can the health worker have data for local action? And we believe that the scalability, configurability are technical, yes, but they are not just technical features. It's more about the ecosystem play. We have to see how the ecosystem can adopt it. It's just a small part, and the tail cannot wag the dog. And we have to make sure the technology understands that very well and work with the ecosystem to make it work. The real question, of course, is, are we investing in technology or are we building solutions that scale, adapt, and stay relevant? Would invite you to scan this QR code, engage in conversations. We'll be able to answer as many questions as we can. And this is a team. This is an approach that we have to do all together. Thank you for the opportunity. And sorry about that initial slide stuff. Thank you.
Thank you so much.